I want to say good evening to each of you. We thank the Lord for this opportunity to gather, and as I shared with you over and over again, is that I'm not just interested in your spiritual growth, but I'm also interested in your learning and having information to make good decisions about your health. So that's why we are doing the Family Month, is so that we know that we have to take care of the whole person. It's just not what happens on Sundays or during Wednesday's Bible study, but it's how we live our lives throughout the week, and not just us, but our families. So is what's motivating us to do what we've been doing for the last couple of weeks. It's been some great weeks of information sharing, and tonight we have a subject matter that I know is very dear to many of us, because many of us have been touched by the subject matters that are going to be discussed tonight. So with that being said, let us bow as we open up with prayer. Our God and our Father, we just thank you again for this day, and we thank you for the opportunity to gather as your people, Lord, that we might learn together, Lord, that we might become more informed about our health. And God, we just thank you for all who have come, and we thank you for our presenters who are here with us. We thank you that they found the time to share with us tonight. In Jesus' name we pray. Amen. It is an honor to introduce our speaker for tonight, Dr. Joan Stalzer. I have just enjoyed the few words we exchanged, and I know that you will find her to be someone who will be very open to whatever discussion we need to have with her tonight. So we will have a time for some questions and answers. Dr. Stalzer is an internal medicine specialist in Fishersville, Virginia, and she has 27 years of experience in the medical field. She graduated from the University of Virginia School of Medicine, and she's affiliated with the Augusta Health. And we're delighted to have her tonight. Her board certifications include the American Board of Internal Medicine. Her professional memberships are the American College of Physicians, the Society of Hospital Medicine, and the American Association for Physician Leadership. So at this time, we're going to have her come and share with us in her own way. And again, there was information in the front that will be available to you after her presentation. Dr. Stalzer.
And then to change the thing. I'll say hello. And then we'll do. Yeah. Okay. So can you all hear me? Okay. Thank you. So thank you for having me come. I appreciate it very much. And the introduction. As you know, I'm a physician at Augusta Health, and I've been there for 15 years. So prior to that, I was in New England practicing medicine, sort of as a primary care doctor. At Augusta Health, I've been working as a hospital physician for 15 years. And just on a personal note, probably very relevant, is that my mother had advanced dementia when she passed away at 89. So having seen it as a physician, but also in a family member, helping my own family after I'd been dealing, helping other patients, having to deal with it with my family was really adds a little something to perspective. The other thing I would like to say is that I brought Kim Galloway with me, who is our head of community case management at Augusta Health. And then probably the most important things that we'll talk about tonight will actually come from Kim, because she knows all of the community resources. She has a lot of experience. And how many years of case management and nursing experience do you have? Oh, yeah, so that's a lot. And so Kim has a lot of knowledge just how to get things done and what resources can be given. So I thought I'd start out with just from the very beginning, which is what is dementia, and we all have an idea of what it is. I hope that we answer these questions as best, and like I said, afterwards we can kind of review any specific questions. The next slide, do I just Oh, gotcha. Here we are. Dementia is actually a really general term for a whole group of disorders that they all have in common. Memory loss, progressive memory loss over time. So this is someone who was previously did not have problems, and all of a sudden they do have memory loss that isn't simple memory loss, like I keep forgetting names, and a lot of us get worried as we get older, we have memory loss, but this is more severe. It interferes with daily functioning. That's dementia. So it's a very general term, and it can be caused by a number of things. So the next. There's all sorts of memory loss that people have. So the most common that we think of is forgetfulness, like forgetting something people told you, forgetting you had appointments, forgetting how to balance your checkbook, all the way to some disorientation, kind of confusion, trouble with specific tasks, making poor judgments that we tend to see. Someone who used to be sensible making judgments is all of a sudden spending all their money, or getting taken advantage of by people that didn't used to happen. So that can happen. And then multitasking becomes extremely difficult, which is already hard, but when you have dementia, it becomes close to impossible. And social functioning, there are some dementias that primarily start out with trouble with social interactions. That is not the most common. The most common, and I'll go into it, is Alzheimer's, which is you actually kind of have preserved social functioning. They seem totally appropriate and socially fine until you realize that there's some basic things they don't. But there are some early dementias that present with behavior changes. That's especially if someone has dementia before age 60. Sometimes they may start acting very strange, completely inappropriate, and then you realize something is very wrong, and so that also occurs. We will mainly focus, and appreciate that, on Alzheimer's disease, but here are many different types of dementia. Alzheimer's is the most common. 60 to 80% of anyone who has dementia has Alzheimer's. However, there may be others, and that's important to know because they do happen, and there may be different treatments for them. So there's vascular dementia. So a lot of people have diabetes, high blood pressure. In long-term diabetes, high blood pressure can lead to small, teeny, tiny mini strokes in the brain that can lead to problems with memory because it damages the brain. And it can be slowly. It doesn't have to be like a big stroke. It can be over time. And then you see evidence of this sometimes when you get a brain scan. Frontotemporal dementia, that's that one that is often presents sometimes with behavior changes or aphasia, like the famous Bruce Willis kind of had that. It's just speech stops, and then that's kind of what happens first. And then there's others, like repeated brain injury, trauma, so that can present dementia. Muhammad Ali, I think people that had that. Alcohol-related. And then mixed is just, you can have more than one of those things, vascular with Alzheimer's. So what causes it? No one really knows why it develops. It does come with changes in the brain, though, that scientists do know about, but just not why it happens. So, and I just thought I'd go into this very briefly because you hear about it all the time, and you may be familiar, but you've heard of plaques and tangles, but that's Alzheimer's. So basically, there are plaques that are a protein called amyloid beta, or beta amyloid, and tangles, which are in the cells made of another protein. And on the next slide, I just put a picture up, and under a microscope on Alzheimer's, the left is normal. Those are normal brain cells, neurons, nerve cells. And the right is Alzheimer's, and there are all those plaques in between the cells, and then inside the cells, it's a mix of these tangles. So, and then the cells die. So, and then it leads to the shrinking of the brain that we see on scan. And so I just thought I'd show just kind of what it looks like, because really the scan of a brain, the one on the right is Alzheimer's, and the one on the left is a normal brain. And it actually does shrink. You can't diagnose it based on that, but because we all have a little shrinking as we get older of the brain, so it's not the way we diagnose it. We actually get a brain scan to rule out other causes of dementia. And I can go to like a subdural hematoma. Some people have a bleed in their brain. Some people rarely would have a brain tumor that causes their problems. So thought I'd throw that up there. Dementia is really common. I'm sure we all have someone that we know with dementia. And it's a disease, generally disease as you get older. You can get it younger, but usually, over age 60, it's relatively common. But once you get over 80, it's 1 in 6. Getting to over age 90, it's close to 1 out of 2 people may have dementia, but not everybody gets it, so it's hard to know. So what to do? What are the testing? It is a good idea to always bring this up with a physician if you feel someone has dementia, because there are other things that mimic it. There's thyroid disease, there's certain vitamin deficiencies, which is B12, there's depression. Sometimes dementia comes with depression. Treating any of those will make that memory better. It's not that thyroid disease is very common and makes symptoms worse, and you just never want to miss it because it would be a shame to miss something that would be treatable. But and then there's other things we tend to do, like I said, sometimes a brain scan to rule out other things. The people that bring that, it's usually the family or friends who bring this to the attention of the physician, because typically, now I'm kind of going with Alzheimer's, the patient does not complain of the memory loss. It's everybody else who notices the memory loss, because that's part of the disease. They don't really seem to realize that it's unusual that you don't, for example, like my mother did not realize my sister was her daughter. So it seemed just funny to her, but to us it's not very funny. But so that is why it's always the family that brings this in. So we can go next. Treatment depends on the cause of dementia. Like I said, if it is some of those more rare treatable causes, it's treated that way. Otherwise, there's management. And going on to the next topic is all pretty much talking about focusing on Alzheimer's, because that's really what most of us deal with. So there isn't a cure, unfortunately. Medicines can help, but all these other things probably even help more, which will be interventions, community services, which we'll talk about. And the goal is to improve function. This is a progressive problem, but can be managed. And so many people have it. I think there's getting to be more awareness, fortunately. So I thought I would, just because I'm here and we do prescribe medicines, I thought I would briefly touch on the medicines that are used for Alzheimer's. And the first 3, you may have heard of Aricept. That's very common. So usually that's given early. It can help, so it helps a hormone stay around in the brain a little longer that we already make. That helps improve function. So it can improve function a little bit in people with Alzheimer's, to the point they may be able to stay home, and function better, and that's worth it. It doesn't change the fact that this is a progressive disease. So those top 3 occur and will be used with mild dementia, and sometimes people will add Namenda, you may have heard of that one, on top, and that also, it adds to the other one, and sometimes that helps. But if people do get side effects, because this isn't curative, we don't want side effects, so we tend to stop it if it's not helping. There is one other treatment and I thought I'd bring it up because you may have heard about it. It came out in 2021. It was all in the news, and it was aducanumab. And it was a big deal when it came out, and it is a treatment for Alzheimer's because there's some thought it could help with a cure, but It was really controversial when it came out because it got sped through the FDA, and there were a lot of really, it didn't really show any improvement. It only, on the microscope, it showed some improvement, but it hasn't yet been proven to have any clinical benefit. I thought I'd put it up there because you may have heard of it. And it's an IV med. It needs very close monitoring. It causes in a reasonable group, less than 40%, it can cause brain swelling and brain bleeding, which is a really not a great side effect. So it was very controversial. You may have heard about it. Everybody's up in arms that why in the world would the FDA approve this? And actually, I'm not sure because we don't prescribe it at Augusta. It is more of a research tool. So I just thought I'd throw it in there because it's out there and it got a lot of press. Let's see here. So the symptoms with dementia although memory loss is a big one, probably the most bothersome for most people is the other symptoms, which is the side effects of that, which is like the agitation. People can get agitated, aggressive. They won't sleep at night, but they sleep in the day, so they're up all night. This happens a lot. They get a lot of delirium, so if they're on medication, even like doses that shouldn't cause a problem. For someone with dementia, they may throw them way off. If someone with dementia gets a infection, like say pneumonia, instead of the typical symptoms of a cough and fever, they may just get confused, combative, agitated, and that we see a lot. So, and then when they go into in the hospital setting, we outside of the normal home setting, more confusion, more agitation, and it's almost like you don't even recognize the person at home who was just had mild dementia but goes in the hospital and they're kind of off the wall. And unfortunately that is what happens. That's why we do like to try to keep people out of the hospital as much as possible. It's generally not great, but sometimes that needs to occur. So next, so the things that we tend to focus on to help improve, what can you do? So the medicines are one thing, can help a little bit, but keeping healthy, regular routines, getting exercise, so all of that's really important. The sleep-wake cycle is really important. So we try, people with dementia, some people do tend to be up all night and sleep all day. We try to keep them up during the day, go to sleep at night. It's just better when people are up all night. It just doesn't seem to go well, probably because everybody else is sleeping, but there tends to be this agitation that occurs through the night, and people don't tend to sleep very well during the day. So that's one big thing. That's one way of addressing symptoms. Next, and on the next slide, these are things that we recommend, and we did a lot of these with my mother. So Post-it notes, how to use the microwave. You push this button, big signs with all the family phone numbers, calm routines, the rugs. So things like tripping becomes much more common. Judgment is impaired. You might need to lock the doors where they usually had free reign. Driving is a big problem. Things of that nature. Also, having the conversation. So pleasant conversation when being patient with the redirection. Not trying to argue about facts or logic, and I learned that personally with my mother, trying to explain, well, since Anna is your daughter and I'm your daughter, we're sister, and that did not go well. She got very angry at me for saying that, so, and then the problem is, like, I understood, okay, we're gonna back away and not have that conversation, but my family members, my siblings who are not in medical field got very, they would cry when my mother would get upset with them. She got paranoid, she would yell at them, and it's just like that. It's not personal, just, it's okay, so it's hard though when it's your mom or your loved one to do that. So, and then the other thing is to care for yourself. That is the big one. And this is where care for yourself is also finding resources for the loved one, finding resources for yourself. Going to the next slide, I'm going to be talking a little bit. I'm going to be handing this over to Kim in a minute. But since dementia is progressive, and we really can't, at this point, do anything to cure it, it does get worse. So you know if that the family member is starting to get a little, has dementia, still driving, plans for not driving, plans for how is they going to get food? Like they can't cook anymore, but they can make a sandwich. Pretty soon they're not going to be able to make a sandwich. So plans for that. Advanced directives are really important. We do see people who, we've had a husband-wife team who both were getting demented and neither has children, family contacts, anything, and then what in the world happens when, or when one has dementia and one doesn't, but the one who doesn't gets ill. Planning ahead with an advanced directive is a hugely important thing. So there are resources for that also. Medical complications of dementia. I did want to mention that people can pass away with dementia, like they don't eat and they pass away. Usually it's of something else, a fall, a hip fracture, a complication of that. But yes, people can pass away with that, but it's usually all of the other things that happen. They're not eating properly, they don't realize, they're swallowing pneumonia and things of that nature. So those are things that happen, and we don't know when they're going to happen. And everyone's course is a little bit different. So what types of planning? I did talk about the power of attorney, getting ready for, anticipate this will get worse. We don't know when it will get worse. And that was something that, you want to plan for everything. You just don't know how it's all going to come about. I know with my family, they wanted, everybody wanted to, what's it going to be like in a month? And we'll see what it's going to be like in a month. We don't really know, but we will plan. So next, I'm going to ask Kim to address this because this is her area of expertise.
Thank you. Good evening. Thanks for having us here. I'm going to go through and reinforce some of what Dr. Stalser said, and community resources are really geared towards safety in the home for patients and for your family members, because that's usually when we get the phone calls of, how are we going to care for them? We work during the day. We need help while we're gone. They live alone. Family may live in another state. So what services do we have available that we can try to put into place to keep people at home? Because we all know everyone does better if they're at home in their own environment. So there is some programs that are available. One is called community-based care, or you may hear it referred to as an EDCD waiver, and that's paid for by Medicaid for people to be in the home. And community-based care is where you engage an agency where they'll send you an aide and that person is there. The EDCD waiver is you can hire your own, so that if you have a family member, a friend who can then be the caregiver for that patient, then you're responsible for the hiring and firing and vetting that person. There is some background checks that go with that, and then there's a facilitator that will help you get that in place. It's paid for under Medicaid, under long-term care Medicaid, which is equivalent to being in a nursing home. So, and you have to meet that level of function as if you would be in a nursing home. I always tell family and the patient, we can screen you for some services, and when the letter comes, it's going to say you meet nursing home criteria. We're not trying to put you in a nursing home, but you have to meet that level of function in order to get the assistance, because everyone's trying to avoid going to the nursing home. And so then they think, oh, you lied to me and you're trying to put me there in the nursing home. And so the financial qualifications for that are the same as if you're going to be going to a facility. However, if you're in your home, then the biggest fear is they're going to take my home and what's going to happen. If you're in your home or your spouse is in your home, then that doesn't count as a resource. And even if you would have to be placed at some point into a facility and your spouse is still in your home, they get a spousal allowance. They have to be able to still pay the bills and pay the insurance and do that. So it's not always the home is going to have to go and what are we going to take care of it. They look more at what outside resources you may have as far as savings, and then you have to spend that, which then takes us to then, okay, let's hire private caregivers to be able to spend down money if you do have those resources that is available. We have caregiver lists of people who have said, hey, I'm a caregiver, can you, help pass that along to me? Those aren't references, we just have a list to give you a starting point as to where to start. Valley Program for Aging Services also has lists of people that are available just to try to give you a jump start. We always tell people, check with your church family, your friends, other relatives, just to see neighbors or someone who's used caregivers to get kind of those references as somebody you know. Adult daycare, unfortunately, we lost the adult daycare here in Waynesboro because that was a wonderful resource for families. It gave you respite. You could go there Monday through Friday, or you could go there just one day a week. If people had family that worked, then you could drop them off and pick them up. Unfortunately, that isn't here anymore. There is one in Harrisonburg. So, if you would be working that direction, or if that was just a good respite place for you, that is a wonderful facility. They will bill Medicaid if you qualify, or it can be a private pay rate, and you are able to go for whatever you set up that you need and want for that. And the neat thing about Generations Crossing, they have a daycare there too, so part of that is they have the children, and so that's always been really good for people to have that cross interaction with people. Respite options, if you are going on vacation, but mom needs some help, or we need to do something, there is facilities in the area like some of our assisted livings or even the nursing home levels where they can just go for a short period of time. We're going to go to the beach for a week, you can go there for a week. They have rooms even at, say, like Royal Care, Birch Gardens, Waynesboro Manor that's here, that if they have a bed, then they will help you have, you can go there for the week. And it is private pay for that, but know that that option does exist. You can go into the nursing home if you would have Medicaid, say to a facility for respite, and know that, okay, we're going away, we just need help, or we're having surgery and someone needs to watch, and then you can come back home. Support groups, there are some caregiver support groups in the area through Valley Program for Aging Services, so that is a great resource because, as Dr. Stalzer said, you need to take care of yourself. You've got to provide yourself some respite and to take care, because when you get exhausted and they've been up all night, some people just need those caregivers in nighttime so that they can sleep and someone else is taking care of them, so you're refreshed and ready to go for the day. And then I talked about VPAS, and then they have a Dementia Friends information, and they have sessions for those to help with that. So options are assisted living and long-term cares facilities. Some of those have memory care units. So if a patient, if the person is wandering, trying to get out of the house, or we're trying to leave a facility, then there are secure units where they can't get out of. It just looks like a normal unit, but the doors are secured. Some of the assisted livings and some of the other facilities have what they call Wonder Guard. So they wear something that looks like a life alert, looks very similar to that. And if they get too close to the door, then the door will lock, and then the alarm will go off. It'll beep, and then so no one can go in or out if someone's too close to that door, so that you don't have anybody wander out. So that is helpful, and sometimes we could use that Wonder Guard and not have to end up in a secure unit. Those are not plentiful in our area. There is one nursing home with a secure unit, so there are limited beds. Some of the assisted livings that are private pay have secure units, but that is pricey. And so it is difficult for people to afford that on most occasions, for long term anyway. Any particular questions for me as far as caregivers and whatnot? Yes, ma'am.
The other day, we were trying to say that Alzheimer's is like 3,000, and I thought that was kind of outlandish, but they were saying that it is now like, I saw something, I said, what in the world? But I mean, it was something in passing, but I didn't read it, so it was kind of crazy.
Yeah,
and every situation for people and families is unique. I mean, I've learned that over the years. I mean, what you need and what your family may need is completely different than what your neighbor may end up needing. So, truly reach out and explore your options and help problem solve. Reach out to us. We are more than happy to just kind of help you brainstorm and to research what your options may be. Because, home health is an option. Sometimes we can, put in a nurse and some therapy and look at the home if we're having a fall risk, and what things can we set up to just, mitigate some of those barriers that you're having being able to stay at home. And then that will give you at least some time to maybe plan for what's going to be the next step. So yeah, everybody's needs and everybody's situation is completely different. Don't always rule out the fact if Medicaid is an option, because especially we can get not creative, but there's ways that may help you maybe meet that criteria, because long-term care Medicaid is different than, oh, I've been told I don't qualify before on straight Medicaid. There's a difference. You may have a copay, but how do I want to spend my money? I'd rather pay that copay and stay in my house than to spend it at the facility. So we can help you understand what they're telling you and to be able to weigh your options. Even if you're over-resourced. I had a gentleman who was like, okay, I need to spend X number of dollars, so I'm going to remodel the bathroom, make it handicap accessible, build the ramp, put a new roof on my house, like all the things. He's like, I'm going to need this before I go. And I'm like, yeah, you're right. So he did all those things, but they were able to spend the money and keep his wife at home. So, there's ways to be able to do that and get the help with that. And if you're married, you don't have to spend all your money. I think, people think they've got to spend down and become, paupers in the process. But technically only half of that money has to be spent towards the spouse that would need the care. So you don't have up to $99,999. So you have an option. You don't have to spend every dime to be able to stay there. Part of that money is yours to take care of you, or your loved one, so that you don't have to spend all of that at once and deplete what you have.
Am I more likely to develop Alzheimer's or dementia with my parent or my grandparent?
So it does, so yeah, there is probably a tendency, if your parent was.
Oh, here, that's why I was sitting here thinking.
So there is some suggestion of familial tendency. If your mother or a family member got dementia, it's much more strong if it's your first degree relative, being your mother or father, sometimes sibling. If they were very young, then that is a little bit, that's a little more likely. If they were older, it's a little bit, it's a little bit of an association. So I think about that all the time. So if, my mother was probably about 80 or so when she started getting it. And so the women are a little bit more, tend to have dementia more, but women have a little bit of a longer lifespan, so they have a little bit more to develop it. And since it's so I would say I wouldn't think that there are certain dementias that are very tied to genetics. Alzheimer's, developing this after age 65, is just a slight tendency. There are things like Huntington's disease, you may have heard of it, where it's a one-on-one. And if you get that gene, you know what's going to happen, and it's going to happen at an early age. Pretty devastating. The rest is just like, so, yeah. To get like a vascular dementia. So it is associated with specifically diabetes, hypertension. However, managing those risk factors are probably the most important. So if you know you have high blood pressure, but you take your medications, you know you have diabetes, but you try to keep under control, then you're going to be less likely to have that problem. Uncontrolled is going to be the worst, because this doesn't happen acutely. It happens over years and years and years. Yeah.
Something I left out was not talk about the medications. If the copays, thank you. The Aricept is pretty widely accepted and covered, but if you have a medication plan that doesn't pay for some of these medications, please reach out, because there are resources to help you with those, and we can explore that for you. So don't say, okay, I'm not going to take this because my copay is outrageous. Please reach out so we can see what we can do to get those medications for you and to try.
My cousin, she said her mother did not go to her mother had dementia at 58 and really went bad in her time. She's 72. She said, "Am I gonna get dementia?" I said, "I don't really know." But she's 72 and nothing indicated that.
Yeah.
But her mother had dementia at 58. She said, "Am I gonna get it?" I said, "If you ain't got it right now, you might not." But it's not my specialty.
Right. Yeah. So 58 is young, but she's 72. So, and she might not get it, you know. So, so when you look at it, chances are, it also depends on how long she lives. Is she live till 100, or is she gonna, you know, because we all are more and more likely to get it if we live longer. But if she doesn't show signs of it at 72, awesome. Mm-hmm. And then that's where keeping healthy, doing all the things, you know, doing things to keep oneself healthy helps to also minimize risk of, and that also means exercising your brain. So that means reading, you know, they talk about puzzles and just sort of, because if you just sit and you don't use your brain, then, it atrophies like anything else. So keeping those things up helps. Yeah.
Question, in the groups that talking about dementia, what is the thought of where, like you may mention that someone might be losing their memory and the person themselves is not talking about it. But, you see it happen, and you need to somehow get to your sister, brother, whoever, and say, let's think about having this test. What is their approach to get there?
So talking about a family member who doesn't really want to go to the doctor, doesn't think there's a problem, but everybody else knows there's a problem, right?
Yes.
Tricky. Yes. So it's a hard thing. And my recommendation would be, you recommend they go into their doctor for a checkup, and you can call the office. There is, so you know, you've heard about HIPAA and privacy. Well, that doesn't apply to you talking to someone's physician. Anybody can call up. You can call up and say, you know, you know, Mrs. Jones down the road told me, you know, she's having a doctor's appointment, and I think she has dementia. I mean, you can actually do that. That is not against the law. It's not against the rules. So for a sibling or a mother, and I've done it with my family members. So I've called my mother, you know, well, no, there's nothing wrong, you know, with me. But I'll call the doctor, and I remember getting like this sort of like, well, I'm sorry, you know, they actually said that, I'm sorry, you know, this is private. I'm like, no, HIPAA goes, only you can't talk to me. I can tell you whatever I want, and I'm going to tell you a lot, because she is not doing well. She's forgetting. And so so that is what I would recommend, is have them agree to see their doctor, because they may get defensive. A lot of times there's just sort of, oh, everything's fine, and we call it, and they'll even make up stuff, because we call it, there's a word for it, it's called confabulating. So you can talk to someone with dementia, and if you just breeze that, they'll just sort of say like, how are you? Fine. Oh, did you go to the ball game yesterday? Yeah, I did. They didn't go. And then they'll be like, oh, did you see so and so? Oh, yeah, I saw him. Yeah, he was great. They'll have a whole conversation. It's just the way it is. So what you have to do is go behind the scenes, talk to the doctor. You can tell the doctor whatever you want. They may not then tell you what they're going to do, but they know now. And that's so important, because the person will show up at the office and say, I'm fine. Everything's great. No problem. And the doctors are busy, so they're not going to, decide to interrogate about this and that and do a whole workup. When someone comes in the office and says, I'm totally fine, doc, there's no problem, they'll be like, great, all right, great, because I got 10 more patients to see, you know what I mean? So yeah. Yeah.
How would it be better with coming out with a better stuff paper, somebody who's early signs, not like signs of Alzheimer's? I forget the name of that, it's just confused, but I don't know the name of that.
A new one that's, a new one?
But you have to be, Medicare will pay for it, but it will have to be someone who's early into it. You can't have it late.
Late. And it's not the one I was talking about before.
This is just something I read about, heard about this year.
Gotcha. I'm not sure which one you're referring to at this point.
Question for Kim. How do, talk about your resources, you have resources. How do people get in touch or know about it? Like, how does the community know, your community, you can help us? How does that information get out to people?
Right.
You ask a lot of questions and they said, people, they can check it, how do they do that?
So if you talk to your physician, or if the family or whatever, then they can make a referral to us. They know we are available, and we'll get those referrals if, family member has dementia or need to explore resources. And it can be not just for dementia, whatever the need may be, affording medications, other issues. Then we can then reach out to the family or to the patient and talk about what we need to do. Yes, so we're still have the ACO for that part, but we also have kind of a section where we can take referrals from those providers. So it can come from anywhere. And I've got my card up here, but anyone can call in. If you call in and say, I need to talk to a case manager, I have some questions, it'll get to us. They'll send it to us, and then we'll reach back out. Yeah.
Oh, yeah.
What's the problem? Has dementia Alzheimer's been for years now? Has there been any closer progress to maybe finding some theory that says this is a cause?
Yes. So there are a lot of resources going into research. So they know this information about what happens. They know the buildup of those proteins occur in the brain. They're working on, in mice and things, certain things that might stop it, arrest it, like stop the development, stop the production, stop the accumulation, increase the breakdown. The problem is it's just, and the brain is so tricky because, like I said, like this other one does have good results under the test tube, but when they give it to people, there are some people's brain that swells, and then, you can't live with the swelling of a brain. Donepezil? Oh, okay, the one, yes. So does that answer your question? And I'll get back to your question. So the donepezil, okay, so what's coming out is a version of Aricept that's transdermal. Oh, that goes through the skin. If that's what you're talking about. So it's the actual, yeah, so it's the same medicine given in a different way. Yeah, and that is for early Alzheimer's. That is for early, just like the oral form, but it's just a different form. So from my standpoint, it's the same med. It's given in a different way, but that might work because maybe it's weekly, 7 days, so they won't forget. So you can just have someone put it on. So that helps. But again, it's not going to be a cure. Yeah. That sounds like a pretty classic story. So yeah, it kind of comes on, it's kind of mild, can kind of get it right, but then finally it's like, no, there actually is something wrong. And then, but you can live many years. There is, speaking of that, I just wanted to tell you that Kim's card is up here, so if you all ever want to grab it, because she can provide great resources if you have questions. I left up here if you are interested. Valley Program on Aging Services has given me, I'm on sort of this dementia board, they gave me some handouts that provide some information about dementia-friendly services. They also gave me this card, which I thought was a really great idea. I would have used it for my mother. And so I just grabbed a bunch because I knew I was coming here, and it says, so if you're out with a family member who has dementia, you could do a restaurant, it can be a doctor's office, checking out. You can give this person, and it says, the person I am with has dementia. They may repeat questions, forget what you told them, take longer to make a decision. It tells people to just be patient, and you don't have to just sort of like wink or nudge, or, you just be like, here. So I'll just leave them in case anybody wants it. And then just some information handouts I printed out, which is from, usually this is a resource that when physicians are looking up stuff, we go to a site called Up to Date. So that's like the physician resource, So I printed out from there some information about Alzheimer's. So anybody, I didn't know how many to print, but I printed a few if anybody is interested. Anybody else?
So I know the Alzheimer's Association has some information on like safety at home and things that you can do. I know I've had some families who, you'll move the locks up so that they can't, if they're trying to get out the door, and so that you have that barrier. I don't know about Wonder Guard, but I know you can set up like those motion doorbells, kind of if you walk by and it sets it off so that they're headed a certain direction. And can do that if you're getting suspicious that they're going to potentially get out of the home and that be unsafe. That is truly, I think, a real pivotal moment for families. Is when a person gets out and you don't know it. It can happen in a split second, and you have no idea. So, but yes. But they do have some recommendations of things to do to help make your house safe. But I know I've had family move the locks up and do those types of things. Yeah, but I don't know that specific. Okay.
It is very different person to person, so it depends on several things. It depends on the stage at which it's diagnosed, because some people are able to get along, say if you live with a spouse who accommodates for the problems, then by the time it's diagnosed, I've had patients who don't know, they come to the hospital and they really don't know, and then nobody seems to realize that they don't know a lot of basic things. They cannot tell me, like they have cancer, they had metastatic cancer and chemo. They have no idea that they did. You know what I mean? That's like probably something you would never forget. They have no idea about that. They have no idea. So some people present, they've actually had it longer. There are highly functioning people. There are some people who are quite highly functioning and accommodate for so long, and then there are some people like that. Like they're very with it. They accommodate, and then they may have a dramatic drop off because they've used all the tools that they can. And then they just, and it happens very quickly. So we see that. And we see everything in between. And a little bit depends on which type it is. If it's Alzheimer's, which is the most common, I'd say that the story you told is a very common story. Diagnosed with mild, because everybody's quite attuned to it, right? So you picked it up kind of early, watched it, and then if they're cared for pretty well, they can live about 10 years. But if they're kind of at home and nobody's around and nobody's helping care, and then they're sort of, then they may get sick, they may trip, they may have a pneumonia, nobody finds them, and then they'll pass away of something else earlier. But even that, even if everybody was the same and didn't have complications, it's a very different course for different people. Yeah.
Someone experiencing paranoia, they can have somebody stealing their electricity or
Yeah.
somebody walking on their roof.
Yeah.
What is that chemical imbalance in the brain, or where is that from?
Yeah. So I think a chemical imbalance is one good way to put it, because it's sort of the whole workings of the brain are chemical. We used to be like, well, that's just in his head. But it's anything that's in your head still has a medical basis. So yes, I think it is. And it may be structural too with the Alzheimer's. So basically there are structural problems, there are plaques, there are tangles, there are hormones going around, which is the chemicals that aren't right. So they do have, and again, everybody's a little different. So some people get paranoid. Like my mother was paranoid, so it's just like, oh, you all are talking about, it's just like, that kind of a thing. And it's very, that's what's so distressing to so many people, in spouses who've been together for 50 years, all of a sudden, the person's confused and they think their spouse has been cheating on. I mean, it's just like it's really, they're not, and then they think that we as providers believe, and it's like, it's okay, we know what's going on, it's fine, So, but it is a chemical imbalance, plus probably a structural problem, plus a lot of things. It's hard to treat because the medicines don't always take care of that.
So if they begin following a lot more does that actually trigger dementia and Alzheimer's?
So usually it can trigger worsening. So it in the sense of just an abrupt fall, certainly repeated head injury over time can lead to memory problems, but just the falling. So what we find when people fall and even break something is that they had dementia, they fell because they did, they weren't really paying attention to what they were doing. They walked outside in the middle of the night and they fell over something. And they get to the hospital or whatever, and that does set them way back. So it looks like their dementia is getting abruptly worse. But what it really is delirium on top of the dementia. So it isn't that your dementia's worse, but but something happened to you. So we tend to see people with dementia, if nothing goes wrong, their course is like this. It just keeps going down. If something happens, like a fall and a hip fracture, they're that, and they might get a little better, but they don't get back to where they were. So it's kind of like this, and it's this, and it's that. So that's kind of how. And then I think I've done this over and over when I take care of people in the hospital, and I show them this. So they took a dip. They're going to get better, but they're not going to get as better as they were. So they keep going this, and then they go that, and so they don't end up as good as they were. What if they don't have dementia? Yeah. Oh. Trigger dementia? So, not in the classic sense, but in the sense that repeated head injury has been known to be an issue that leads to dementia, but that's more of a long-term thing. For example, I guess, Muhammad Ali, who, had that repeated, but he wasn't, and then later on got dementia. So it triggered something later in his life. And that is the thing that happens. So not in the classic sense, but it can be a cause down the road, yeah. Yes. Right. So, So later, they will get it, but it wasn't that it immediately triggered, and it's still being worked out, but yes. Yeah.
So there's the research that shows that there's a relationship between the football fans and dementia.
Yes. It's a huge area of research, traumatic brain injury. It's in fact, it's a hot topic now. Huge. And yes, they have found that there are changes that occur in the brain. There are lawsuits against the NFL. There's and there's a lot of research because where there's money, they're putting research in it, and there's a lot of interest in this. I think. And there were scandals like was the Football Association, you probably have heard it, were they trying to suppress that we knew that this was causing this problem. But yes, it absolutely is now known as a true fact. So it's not everybody that has an injury, but we know that repeated injury can lead to dementia. Yeah.
The other thing is I noticed nursing that communication and we're like, man, we're so confused, what in the world is going on? Naturally, at a B level, we follow.
Oh, yeah, right. Yes.
Down and we thought, I'm really confused one. Now, and I remember particularly urologist tells me, hey, check that level, and we're totally confused because of that. So sometimes neural like sodium can go crazy and different things can also cause confusion as well.
Right. So exactly. So and those wouldn't be called dementia. So that would be more delirium related to. So that's what you have to tease. And that's why when we do all the blood work and whatever, if your sodium is very low, you're going to be completely confused. But it happens quickly, and dementia happens slowly. So if I'm normal today and I'm not normal tomorrow or next week, it's not dementia, unless it's a very rare disease called, there's prion diseases, but that's very, 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 very rare. Any other questions? Okay. Very good. Well, thank you for having us here.
Well, thank you both for coming and sharing with us. Some very good information, some good questions. And it's good just to have this information, because as I've said over and over again, I think that all of us have come in contact with someone, who's dealing with this, and as caregivers especially, it's good to have this information so that you can provide a quality care, and sometimes we realize that we can't do it, and we do have to seek, outside support, for that. So thank you both for coming and sharing with us. We would like to give you something just to say thank you for taking the time to come out and share with us. Kimberly? Yes. I know. You can blame Vermel for that, okay? Yeah. I handed it to her and she put it in the envelope. Yeah.
I have one more question. As family members, how do you treat the family members that not to make her or him feel that you are that something's going on with them? How do you, and in high school, how do you do that? If somebody can help get out, that's like it's working out.
Tell me exactly what you mean again. How do you treat a family member?
You feel like they remember your sister or brother.
Mhm.
And you going the rest of your siblings to be so honored that they are saying things to her or him that is causing them to bring the person that you feel like after we make them feel worse.
So how do you treat how do you talk to family members who are reacting, who are, and explain? So what I recommend generally, that's kind of what I did with my family members, was explain that this is a brain disease that the person has. And anything she said, I also say that this person's not in charge anymore. So they treat them, that's sort of like a child. Others are in charge. So, and so don't get upset. It's sort of like this, take yourself out of yourself and do not get upset. So it's a little bit difficult. It's a difficult sort of thing, but they have to. The only thing I know is, even from my own experience, is sort of talking to like family members all upset and everybody's crying. Mom said this to me. Mom said she, never. Mom won't remember. Mom's not in charge. And we can't do this because mom, she's not in charge. We're in charge. We're not going to, don't talk about subjects that are upsetting. So it's sort of getting people, it's still your mom or it's still your sibling, but we have to talk to them differently. They're still a loved one, but we have to treat them differently. And there's certain things we can't talk about. It gets her upset. So it's just like, take it, and you have to be very unemotional about it. It's tricky because I didn't have 100% success, but they have to sort of step aside, and this person's changed now, so we're going to have to do it a little bit differently and have them see that. They have to understand that, and if they don't, it's very tricky.
Okay.
Piggyback on that last question, once the diagnosis is made, is there not a family consult provided by a doctor so that everybody can hear the same thing at the same time?
There should be, it depends on the physician. It's very common, so, I think family members should request it. Because, it's so common, physicians really need to request it, get family members together. And you all being here tells me that you're here for, some people have someone, don't have anybody that takes the bill. The physician should do it, but they're also very busy, they don't always have family willing. It's a good thing to do.
Are there any more questions? The pastor had to step out.